Hello, ladies and gentlemen. Welcome back to our last lecture on arrhythmias. So today we're going to talk about the bradyarrhythmias. So bradyarrhythmia is basically a heart rate that's less than 60 beats per minute. Okay, so when its heart rate is less than 50 beats per minute, it's referred to as marked bradycardia. Bradycardia. And you guys know that, of course, the bradyarrhythmia means a slow heart rate. So, and of course, the signs and symptoms of bradycardia will be almost similar to the tachycardia, but in much more like a fainting type of signs and symptoms. So, what I will do is I'll just explain you some signs and symptoms of how the patient can present. They can present possibly with syncope, that can present as a faintness, like a fainting type of situation, or lightheadedness, as we can refer it to, lightheadedness, and let's say if the blood supply to your brain is decreased, you'll have memory problems as well, memory problems. So possibility of you having fatigue, you can develop fatigue due to less blood supply going to your body, due to the less decrease in number of beats of your heart. Okay, so bradyarrhythmia basically is decrease in the heart rate that can be developed from decrease in the firing of the SA node or the pacemaker. Let's just erase all that and go ahead and try to describe the bradyarrhythmia, put an algorithm type of thing on how we're going to tackle this lecture today. So when we talk about bradyarrhythmia, we can say, let's say, this is how we're going to take care of it. We're going to talk about sinus bradycardia, then we're going to talk about AV nodal blocks, and I'm not going to talk about bundle branch blocks in this video, but I'll make a video separately for that to explain a little more in detail on how the ECG findings and what are some therapies that are associated with bundle branch block. But as far as it's associated with the exams, most of the time, if the questions do arise, it's about how do you treat a bundle branch block, or how do you, for example, because what are the causes of bundle branch blocks? That's mostly the question will be like. It's very hard to be, I mean, it will be unfair for them to ask you to find like detect an ECG abnormality for bundle branch blocks, even though it's easy to find it, but just for a general cardiologist, it's much more easier than a student who is just going for step 2 or step 3 exam or MCQE1. However, so when we talk about sinus bradyarrhythmia, we're going to talk about the pacemaker problems, and now we're going to talk about AV node. The AV node, when we talk about it, we're going to talk about first degree block, then we're going to talk about second degree, and then we'll talk about third degree. So this is the most important part of this lecture. And in the second degree, we have two types, Mobitz type 1 and Mobitz type 2. Okay, so I hope you guys understand how the algorithm is how we're gonna follow this lecture along. Please follow along, and if you don't understand something, just try to write it in the comment section, and it might help me as well understand some points that I have not explained well enough. But I'll do my best to make sure that I can explain you guys bradyarrhythmias. So the first thing we're going to talk about is sinus bradyarrhythmia. Let's draw a heart, ladies and gentlemen, and put our sinus node, our AV node, and then bundle of hairs, and then bundle branches. So basically, when the sinus node starts to get less influence, for example, either due to less, it's more influence of vagal tones, for example, can decrease the sinus node firing. That's the one thing that the cause can be, that the bradyarrhythmias can arise in the sinus node, right? Another one is, for example, if you block the sinus node with drugs, medications, for example, beta blockers, calcium channel blockers, these are all decreasing the firing of the sinus nodes or the AV node and the sinus. AV node is the conduction system that transmits it to the bundle of His and all, but the firing starts at the sinus node. So it can, the calcium channel blockers and the beta blockers can decrease the sinus node firing. So it might lead to bradyarrhythmia and the signs of fainting, lightheadedness, and all that. The syncope, basically, possibly chest pain as well. Another thing that can cause it is, for example, hypothyroidism, right? Hyper causes increase in heart rate, hypo causes decrease in heart rate. Obstructive sleep apnea, hypoglycemia, sick sinus syndrome. As you guys know, this can possibly increase or decrease the heart rate. So this is very important for you to know that sick sinus syndrome is basically it can increase the heart rate abnormally or it can decrease it. So that's why it's very important for you to be able to put this under bradyarrhythmias as well. And you can sometimes. Okay, so we understood the causes of sinus bradyarrhythmia. What are some ECG findings? Now when we go to the ECG findings, we can talk about there's normal axis. There's a normal axis. To have a normal axis, we have to have a positive P wave in lead AVF and lead 1. So that's a normal axis. So in sinus bradyarrhythmia, you have to detect that the axis has to be normal in order to be referred to as sinus bradyarrhythmia. Then the rate is usually 60 beats per minute less, is known as marked sinus bradyarrhythmia. If less than 50, it's marked sinus bradyarrhythmia. Less than 60 is usually normal sinus bradyarrhythmia. Marked sinus bradyarrhythmia is anything less than 50 beats per minute. Okay, so possibly, as it says in here, it can be seen in normal adults, particularly in athletes and in elderly individuals. Of course, you can tell that as you age, you fibroses, like you can fibrose the pacemaker cells, and particularly aging can cause that. So decrease in aging is okay sometimes to have less heart rate, and particularly also in athletes that are that have training already been trained, so a lesser heart rate can keep their body functional at a very less heart rate. So that's okay with that. And basically, you don't need any treatment unless you want to just treat the underlying cause, and just if they're symptomatic, you just give them atropine. And if they're basically pacing is required for pacing for sick sinus syndrome. That's all. So let's have them look at the ECG. If you guys can tell the ECG, look at it. There's a normal P wave. Sorry, this is a T wave. I'll just start from here. This is a normal P wave, and then Q, R, and then S, right? And then again T. So if this is normal, if the sinus rhythm is if the impulse is generated from the sinus node, then of course our ECG looks pretty normal for us right now. So the only thing I can do is to calculate the R to R and take the number of boxes between these two R to R, and just 300 divide by the number of big boxes, right? So it's going to give me the beats per minute. This is the heart rate, 50 beats per minute. So that's why we can tell that this is sinus bradycardia. I hope you guys understood this. So just take the ECG, find out if it's the firing is from the SA node, and then calculate the heart rate. It will give you guys the normal heart rate per minute, and then you can tell if it's sinus bradyarrhythmia or sinus tachycardia or whatever you want to name it. So I hope you guys understand sinus bradyarrhythmia. It's not as complicated. It's just that you have to understand the sinus node is under some sort of influences, drugs, vagal tone, or it's kind of like, not getting enough blood. It could even sometimes ischemia can cause sinus tachycardia. Sorry, sinus bradyarrhythmia. That's about everything for sinus bradyarrhythmia. We'll move on to AV conduction blocks. Okay. So when we talk about AV conduction blocks, ladies and gentlemen, I told you guys that there's first degree, second degree, and third degree. The first degree is the very like honestly generally the best one, because there is no treatment required for this, and it's usually found in most of the time in healthy adults. So honestly speaking, there is no, I can't find any reason that why does this happen. But if you have this for a general knowledge, and if you want to go deep into it, you can search for it in the medical books, and there might be some sort of causes that has the reason that increases the prolongs the PR interval. But overall it's very normal. They have been it has been shown that it's been normal in healthy adults, and it's very frequently it's found, so it's not all the time present. Okay, so if that's the cause, we have the ECG findings. We say the only thing that we notice is the prolonged PR interval. So the PR interval starts from the start of the P to the beginning of the Q. So that's, it should be greater than 200 millisecond to be considered a first degree block. Correct? All right, or 0.2 second. That's what we call a prolonged greater than 0.2 seconds. So that's what we call a prolonged PR interval, and this is the first degree block. Let me just make this a little bit bigger so I can explain this to you guys. So let's say if we take this part as the start of the P, let's count if it's greater than, okay, so 1 box, that's 2 boxes, 3 boxes right here, 4 box, and this is 5 box, right? And this is 6 box, and this is 7 box. So of course it's greater than 0.2 seconds or 200 milliseconds, and that's why its PR is prolonged, and we can refer it back to first degree block. But however, you have noticed there's only just prolongation, nothing else, no drops in QRS, no nothing other than prolongation. That's why we refer to as first degree block, and no treatment is required. So we'll move on from the first degree block to second degree blocks. As we said, the second degree blocks consist of 2 types. Type 1, Mobitz type 1, and so second degree block, Mobitz type 1, and Mobitz type 2. So in Mobitz type 1, before I go any further and explain you the causes and anything else, just ladies and gentlemen, remember that the only difference between these guys is that the prolongation of the PR interval. In type 1, what happens is the PR interval starts to prolong slowly, and it becomes much more prolonged. In type 2, the prolongation is constant. The PR interval is it's constant. It does not prolong and then drop QRSs. So in Mobitz type 1, what happens after the first time it prolongs, the second time it prolongs longer the PR interval, and the third time it prolongs longer, and then all of a sudden a drops QRS. So it's kind of it occurs very frequently. I mean, not frequently, it occurs not all the time, but usually when it occurs in this manner. However, when it occurs with Mobitz type 2, the PR is constant and it does not prolong, but however, you have more drops, more QRS drops, and you do not have any idea. It's unpredictable, basically, that when is the QRS going to drop or when is it not going to drop. So let's just go over, have an overview of what I mean by explaining what I explained to you guys. So here we go. Mobitz type 1. What are the causes? Triggers usually reversible. Following surgery, increased vagal tone, and right coronary artery mediated ischemia. Okay? And ECG findings. A gradual prolongation of the PR interval precedes the failure of conduction of a P wave. This is also known as a Weckenbach phenomena. Okay? The AV block is usually in the AV node or proximal. So meaning it's either before or somewhere around the AV node. That's what it's trying to say. Like, look at it now. Let me just put this up, the ECG, so I can explain you guys what I'm trying to say. Look at this PR interval from here to here, PR interval, and then look at this PR interval from here to here, right? And a drop QRS. That's a drop QRS right here. Or look at the QRS PR interval from here to here, and then look at the PR interval from here to here. So it was this small, and now it is increased, and then all of a sudden it had another QRS drop, or it will have another QRS drop just here and there, but it doesn't occur. It usually occurs after prolongation of the PR, and then a QRS drops, but it's not an unpredictable. It is more predictable than the type 2 mobits. Okay, so I hope you guys understand this part. It's not as hard because this is the only one that has a prolongation of PR interval, and the longer the PR gets, then all of a sudden you can have a QRS drop. So usually they don't have, there's no treatment for this as well, and if there is any treatment, is the mechanism, underlying mechanism is by taking care of, for example, decreasing the vagal tone, or providing taking care of the ischemia if there is ischemia happening, and anything that's triggers are usually, as it says, reversible. So possibilities are that this is not a long-term problem, and it can be taken care of. And so the problem is now, what we have a problem with is what we have a problem with is type 2 mobits. Type 2. The type 2 mobits is usually caused by ischemia, myocarditis, status post cardiac surgery, meds that slow AV conduction. So anything that calcium channel blockers, beta blockers, digoxin, and all these can slow the AV conduction. So therefore, ladies and gentlemen, it is not important what causes it. It's about the ECG findings that you guys gotta have to look at. So let's just go back to the ECG findings. Before the ECG findings, I want to read this for you guys. So this says the hallmark of this dysrhythmia is constant, as I told you guys, constant PR interval with the missing QRS complexes, right? Okay, so this dysrhythmia may present in a couple of different ways. A QRS complex occurring in specific pattern in a ratio with P waves. This is often referred to as 2:1 or 3:1 block, depending upon the ratio of P wave to each QRS complex. Okay, so what it's trying to say, like, if I'm going to show you guys a little bit of example in here on how this what it means, is if you guys look at 1 P wave, 2 P wave, 3 P waves, right? So this is known as 3:1 block. It means for every 3 P waves there is 1 QRS occurring, correct? But however, if you guys notice the PR intervals, look at it. PR interval here, look at the PR interval here, look at the PR interval here. It is all of similar duration. It's not, so it means the PR interval is constant. PR is constant, but it's unpredictable, and QRS drops much more often. And usually this can lead to a 3rd degree block, and that's why it's required. The treatment is required for this, and the treatment for this guy, the type 2 mobits type 2, is a permanent pacemaker. Let's say if this was a 2:1 block, it means that there would have been 1, 2, and then a QRS happening. So QRS, for example, happening here. So that's why a 2:1 block means for every 2 P wave, 1 QRS has been basically occurring. All right, guys, so I hope you guys understand this part too. It doesn't really matter. It tells that AV block is usually distal to the AV node, bundle of His, increased risk of high grade or 3rd degree block. Yeah, we kind of know this thing. And QRS complexes occur more in unstable, unpredicted manner. All right, so that's about type 2, and the treatment is permanent pacemaker. Remember that. And now we'll talk about 3rd degree AV block. And this is mostly that, of course, many of you guys know that if 2nd degree requires a permanent pacemaker, the 3rd degree for sure requires a permanent pacemaker. So this is why the causes of third degree block are ischemia, fibrosis, and cardiomyopathies. That's the causes for third degree block. And some ECG findings. This is also known as complete heart block, okay? So basically, what it means is that the atria and the ventricles act on their own, basically. This name more accurately describes the electrical event or problem occurring within the heart. As a result of disease or MI, there is a blockage preventing electrical impulse within the atria from entering the ventricular conduction system. So essentially, as I told you guys, essentially the atria and the ventricle are electrically separated, dissociated from one another. Okay, so basically, now this is a third degree block. And when it comes to third degree block, we will have a look at the ECG. Let's have a look at it. So the first thing we're going to find out is, let's see, how is the rhythm. Rhythm is from R to R. Usually in this ECG, it's pretty normal, regular, but it can vary. So the rhythm is variable, actually. It can present as a variable. It can present as a irregular or regular. What else do you notice? Do you notice the P waves around here? So you see 1P wave, 2P wave, and then QRS, right? So the rates in atria are increased. The rate atria has much higher beat and ventricles have less beats, right? So 2, 1, 2, 2, and then 1 only, QRS. Again, 1, 2. This is a T wave. But sometimes you can have even buried P waves that are, you cannot notice it. So some are upright and some are buried. So it's kind of hard to detect if it is or not. But only other thing you can notice is the QRS duration, which is greater than 140 milliseconds. And the PR interval is usually variable too. So that's about how much information you can get from the third degree block. And if you notice it, look at the PR interval from here to here, and from here to here, and what else can I show you? And from here to here. So it's, you can tell it's pretty variable. It's not like constantly increasing or not staying the same or something like that. So it's just generally basically variable PR interval. So ladies and gentlemen, I hope you guys understand this. This is a little bit more of like the atria is acting on its own, the ventricles are acting on its own, generating their own paces. For example, as we said, third degree block is the one that's mostly dissociated because it's a complete heart block. The AV node is usually it's just a separate, like for example, let's say we have a separate, atrias are acting separate and ventricles are acting separate because of this is block, complete block of right here. And so the bundle of His and the bundle branches are the one that are actually taking care of the pacemaker activity of the ventricles. All right, I hope you guys understand this, but what I'm going to do is I'm going to make this a little bit more easier for you guys to be able to understand the topic much better. So what we will do is we will go ahead and we'll kind of try to create an algorithm to be able to understand how this can be taken care of, the AV node heart blocks. So let's say we have some common causes, right? What are some common causes of AV blocks? So of course it's either congenital, ischemia, or infarctions, right? Okay, and some medications. Let's see, my pen is not working better, a little good today, so I don't know what happened to it. Medications, so high vagal tone. These are some common causes that can happen. For example, myocarditis, and some electrolyte abnormalities. All right, so let's say we have these as a common cause, and somebody presents to you with a heart rate. You're going to do, somebody presents with fainting, chest pain, dizziness, and all of a sudden what you do is you have to go do an ECG, perform an ECG, right? So you're going to perform an ECG. What do you do is you perform an ECG and you're going to detect and see, okay, what are you going to look in the ECG for? Are you going to look, for example, for, so the only thing you're going to do is you're going to measure an ECG, you're going to measure R to R and PR intervals. R to R intervals and PR intervals, right? So these two you have to measure in order to be able to find out what's happening. So let's say if the R to R is varying, if you're varying R to R intervals, varying R to R intervals, okay, and or you have a fixed, R to R interval. Okay, so let's say you have something called, if the R, when I say R to R means this is what I'm trying to say, ladies and gentlemen. R to R, from here to here. It means if it's changing, then of course it's varying. If it's fixed, it's the same, right? So let's say if we have varying R to R interval, correct? How is our PR intervals? Is it constant? Constant PR interval? Constant PR intervals. Is our PR interval constant or no? That's what we want to make sure we have. If it is yes, then if it's yes, then we have a second degree AV block. Which type? Mobitz type 2. Mobitz type 2. Of course, yes with a drop QRS, right? Drop in QRS. So that's Mobitz type 2. If it's no, constant PR, if the PR is not, interval is not constant, of course, then we have what? Second degree Mobitz type 1. Mobitz type 1. Of course, right? So if it's going to be progressive, because it's not constant, so of course it's going to be progressive. Progressive lengthening of PR interval. All right. I'll just go review this once again, but I want to make sure that I can write this up quickly for you guys so you guys can understand what I'm trying to say. And let's see, we have a fixed, now we have fixed R to R intervals. Okay. Is the PR interval greater than 0.2 seconds? 0.2 seconds. And is it constant? Is it constant? Right? Of course, in this side, we also had a prolonged P wave rates, but prolongation was progressive lengthening, and in here we didn't have much. On this side we didn't have much prolongation, but it was a constant PR. So on the fixed R to R interval, we're going to see is the PR interval prolonged, and sorry, is the PR interval prolonged? Yes, greater than 0.2 seconds. And is it constant? If it's yes, sorry, let me just draw this. If it's yes, then we have first degree block. All right, AV block. If it's no, then we have third degree AV block. AV block, and of course there will be no relationship between P and QRS, P wave and QRS. So that's why we'll have third degree block and we'll have a first degree block in here, because yes, there's a prolonged PR interval on this side. Prolonged PR interval is greater than 0.2 and it's constant. It doesn't usually lengthen at times, but it just stays at in here. It's not, it's no in here, so we have third degree block because there's no QRS, basically a loss of AV node dissociation, atria from ventricular dissociated. Okay, ladies and gentlemen, I hope you guys understand this, but let me just go quickly review this for you guys one more time. We said some common causes of heart block or congenital ischemia, infarction, medication, and high vagal tone, myocarditis, electrolytes abnormality, and all that thing. What we're going to do is we're going to say, let's say somebody comes, we're going to do an ECG for them. Of course, when we perform an ECG, we're going to measure the R2R interval and we're going to measure the PR interval. Two things we're going to measure in order to find out what are we dealing with. If the R2R is varying, R2R interval is varying, meaning from one R to another R, if it's sometimes increasing and sometimes decreasing, what is it doing? If it's increasing, if it's decreasing and decreasing in duration, we're going to find out what's our PR like. Is it constant? Is the constant PR intervals or no? If there's constant PR intervals, yes, we have a second degree AV block, right? And it's not prolonged. If it's prolonging, then of course we have a type 1 Mobitz. That's very easy to understand. And now we're going to go to the, let's say if the ECG tells us that it's a fixed R2R interval, so the R2R is fixed, then we're going to say, okay, what is the PR interval like? And the PR interval is greater than 0.2 seconds, and is it constant or no? If it says yes, it's greater than 0.2 seconds and it is constant, then we have first degree AV block. As we said, that the first degree AV block is just a due increase and prolongation of the PR interval. And if it's not constant and the PR interval is greater than 0.2 and is constant, but that is not really true, it doesn't hold true, so we have a third degree block, and it will give us it will show that there was no association between P and QRS. I hope you guys understand this lecture on bradyarrhythmia, ladies and gentlemen. And as I said, that if you don't understand anything, please write in the comment section, and I will try to see if I can answer it, or somebody else that might be able to answer you guys the answer to your questions. But please repeat this over and over, and it will give you an idea of what are you missing in your for this part of this lecture. All right, thank you very much, ladies and gentlemen. Have a great time and see you guys soon. Take care.